Hi, cohort colleagues. It's Jennifer. We are going to be talking about the targeted needs assessment today. I've put together a presentation to walk us through an article and some of the salient points related to our assignment. And although I've gotten the audio to work, my IT department was not able to help me get the video going. So you'll have to just trust that it's me by the sound of my voice. So let's get started. This is module 4 of our curriculum leadership class, and we're looking at current 6 steps, actually step number 2, which is the targeted needs assessment. As I said, we're going to look at the specific learners, the learning, and the environment in which we want to assess our curriculum. Rather than repeat some of the wonderful slides and presentation that go with this module that Sarah has already posted, I have taken an approach of walking us through the points in our template. So I'll be asking you questions along the way to confirm via your draft and mine what we need to assess in order to put together a targeted needs assessment. So the first part of step number 2 is to identify your target learners. Beginning with the identified problem, the end in mind, that was well fleshed out in your general needs assessment, which we did in the last 2 weeks, you need to ask a couple of key questions. First, who are the learners that I should target to address this problem that I've identified? And so I'll stop and ask, have you specifically narrowed in on your learners that can address the problem that you identified in the general needs assessment? From there, you'll ask another question. Will training this specific set of learners make the most significant impact to the problem identified? Is that the case for yours? And if so, can you confirm, does this hold true in considering other potential learners that you could have identified or that are related to this problem from your general needs assessment? And then can you confirm that you can justify the identified group of learners to the stakeholders for which you're going to be taking your targeted needs assessment data and presenting the case for what needs to happen within your curriculum, whether it be to develop new curriculum, revise existing curriculum, etc. So from there, we've identified our learners. We need to learn a little bit more about them, no pun intended. So the second part of this is to identify the characteristics about that define this group of learners that you've targeted. So you want to think about what is their prior training, if any. It could be extensive, like we've talked about in several scenarios and articles that were given as examples. It could run the range, as Helene described in her discussion last week in Robert's class, where she's bringing together cross-professional trainings with folks that start out at novice, fresh out of school, all the way to decades of practice experience. So think about your learners. What is their prior training, and how does that impact what you may propose downstream? Within this context, proficiency. We've talked about this several times, and I found it helpful to go ahead and categorize them. Are they novice? Is this going to be a curricula that is completely new to them? Are they developing? Are they proficient, moving towards mastery, or are they actually masters? And again, that could be multifaceted depending on what type of group you're targeting. But in looking at this specific needs assessment, which by definition is targeted, you want to be narrowing that down. And then next you'll talk about performance. Do you have ways to assess what their performance is related to the curricula of interest? So do you have access, or do you know their prior performance and the metrics on which they were evaluated, whether it be testing, grades, observation, etc. And then do you know what level they're currently performing at and what metrics are in place to assess their performance at this point in time? From there, you move on to attitudes. And attitudes, beliefs, or perceptions will play into a lot of the considerations you need to make in understanding how your learners will actually approach the curricula or receive the curriculum. So If you have existing curriculum, you want to assess what their current attitudes, beliefs, or perceptions of what is in place. If this is new, then you may be limited to only looking at the topic itself and trying to identify the attitudes surrounding the topic or the problem that you've identified in order to develop curriculum. And then one other aspect is learning. What are the styles of learning in order to reach this group of learners? What are their needs? What are their preferences? And then relative to actual teaching or learning methods, what is their familiarity with different types of methods that might be employed, and or any preferences in the types of methods that work well with this targeted group of learners? This takes us into the environment. So we're looking at targeted group of learners. We want to examine the environment in which this is all occurring. And so within that environment, the first question you ask is curriculum status. Does something already exist, which we've mentioned several times to this point, and or are any planned? Are you coming in at a point where there's planning and development already in motion? And then obviously the third being that there is no curriculum and you're trying to define a gap. Within developing your curriculum, you need to ask questions about this environment. Are there any barriers? And then the flip side of that, of course, are there any supporting or helpful factors that might enable or reinforce the curriculum you want to bring forward? Moving to implementation of your curriculum, again, you ask the same questions. Are there any barriers that will have to be addressed in terms of trying to implement the curriculum I'm developing or revising? And then that follows, are there any supportive factors, once again, that might help enable curriculum implementation or reinforce the curriculum that you're implementing? And then finally, resources. Are there any existing resources that can support your specific curriculum and ideas that come back to the heart of your problem and what you want to accomplish? Moving from the environment into stakeholders, these are the folks that have any sort of connection or relevance to the problem, and ultimately will be folks that have a stake or decision making or impact from the curriculum that you are assessing. So you need to ask, who are your stakeholders in the targeted learning environment that you're looking at? This could be institutional administrators, school administrators, accrediting organizations, which we'll see an example of that in a moment, faculty, course directors, instructors, program coordinators, any sort of administrative or content managers. And then, of course, there are affiliated organizations and professional contributors where there may be impact from or on your curriculum based on what professional organizations want or require for those being trained in certain areas of, in this case, healthcare or medicine. So moving through, and as I mentioned, I want to reinforce, we are moving through the template in terms of the types of questions and things that you need to consider in your draft targeted needs assessment. And then we'll move into the example. So here we are at number 4 within this step 2 of CUIN's 6 steps. And this is the learner and the environment assessment of what don't you know? What are the unknowns? And this becomes very important because this is where we're going to really start defining the targeted needs assessment and how we're going to uncover this information within our learners and the environment. So starting with the learners, again, you ask, what don't you know about this group of learners? What are the priorities among those, if there are several different points that you need to know in order to proceed? And what are the methods or resources that might help you acquire that information? And then moving to the environment, you want to ask the same question. What don't you know about this environment? What are the top priorities? If it's a long list, what do you need to focus on in order to proceed? And then finally, what methods and resources might help you to acquire that information about the environment itself? This takes us on to piloting, and that is the targeted needs assessment. You're going to look at a group or subset of learners that you can pilot the methods that you've just identified in your unknowns in order to obtain the information. And this is where we move into a pause. So were you able to step through each of the items in your targeted needs assessment template and tailor it specifically to your cause or problem that you're trying to solve. The asks for this are, who are your learners? Who are the stakeholders? And what is the environment in which you're going to be operating? So now we're going to move into the example. I posted the article Sunday evening that we're going to look at as the example of a targeted needs assessment. And so with that said, let's move right into it. I picked an article that's actually from the Journal of Community Hospital Internal Medicine Perspectives. It's an open access article with the reference at the bottom of the slide, but the title is, Do Medical Trainees Feel Confident Communicating with Low Health Literacy Patients? And we're going to go through each of the template steps and apply it to this article and this specific targeted needs assessment as an example. So piloting my problem or my assessment within my learners and environment is encompassed in the research and article here. Do medical trainees feel confident communicating with low health literacy patients? The problem is that health literacy skills are not being employed by medical trainees, and they believe they are actually using these tools. In most of the literature, it cites that there is an overestimation of physicians, no matter what the level of training, they overestimate their ability to identify patients with low health literacy skills, and that they're communicating clearly and in a fashion that's easy to understand regardless of low or moderate health literacy within their patients. The literature would contradict this estimation by physicians, so we want to look at specifically my population of medical trainees in the article and how confident they feel in communicating with specifically low health literacy patients. So the targeted needs assessment itself takes on the form of research on whether the level of training impacts trainee knowledge, attitudes, and behaviors. And I apologize, I moved my slides around, so the first reference defining these actually occurs after the acronym. But this is K for knowledge, A for attitudes, B for behavior on health literacy skills. So let's look at the learners. The target learners in this case are medical trainees. The article specifically focuses on internal medicine residents and medical students, and the pilot group that they're looking at within this are community-based IM residents or internal medicine residents and the medical students in two Pennsylvania and Maryland programs. The potential for impact here, in asking myself this, I had to go back to the original literature, which is cited in the article as well, that issues with low health literacy among U.S. adult patients is running about a third, a little over a third, at 36% in general. And there's additional literature to support the fact that these low health literacy patients rely heavily on their physicians to obtain their health information and directions for care. So the target group is still in training, and we have the ability to assess them, and their training curriculum is accessible. So the potential to intervene and impact my learners to then directly go into the clinic because they are still in training and going through rotations and training with experienced physicians, again, direct impact on this problem of how physicians are communicating with low health literacy patients in this pilot group. So support for targeting this group is that the ability to compare levels of training in this particular target population. I have both medical students and residents in these programs in Pennsylvania and Maryland that the article is assessing. Per additional literature cited in the article, health literacy skills are not adequately covered in U.S. residency programs overall, and direct access to these target learners for observation, research, intervention with new or revised curriculum, and then reassessment is really optimal in this pilot program. So let's look at the deeper characteristics of my target learners in the article. Prior training, they've had initial medical school training. That should be an even playing field for the most part. And that does include, according to the article's reference, that communication skills in general are taught as part of the training program. We are looking at 2 levels there after those medical school students that are still in formal training, as well as those in the residency program. Their proficiency, I believe I have a range here, all should fall somewhere in the developing category, although my medical school students are going to fall further at the left-hand end of a spectrum, novice, beginning development. The residencies ideally are moving out of development into proficiency at the right-hand end of that spectrum. Their performance, if you have access to medical records, program observations, etc., you can assess their prior and current performance. Again, they are in a formal training program at 2 different levels, medical school and residency, so there is a lot of structure around them to assess their performance and to use that in order for progression to their next steps. Attitudes are a big part here, and that is where this article, this pilot program really focuses on is what are the attitudes around this issue. Their perceptions and the focus of the assessment is that MDs, physicians are not prepared and they're not using health literacy skills as needed, and they overestimate their patient health literacy levels in those clinic interactions. The expectation here is that the residents, which are more advanced in the training program, will actually exceed medical students. So we're going to find that out as well. And then from a learning characteristic, their current approach to learning is in the context of medical school, which means both didactic courses, clinical rotations, observations, and mentoring. The stakeholders for this particular article will tie into institutional administrators in these medical schools in Pennsylvania and Maryland. Accrediting organizations, in this case, there are 2 key groups, LCME for U.S. medical schools and residency programs, ACGME. There's also the faculty at the medical schools in Pennsylvania and Maryland, the medical school instructors, curriculum coordinators, the residency program coordinators, other administrative leaders, and associated instructors, and then the healthcare professionals themselves that are working as part of the care teams in the clinics and interacting with the same patients that our residents and medical students are through their rotation. So the environment, I've mentioned this several times. I'm sorry it does get a bit repetitive, but you want to deep dive and make sure you understand your learners and their environment, as well as your learners in their environment. And so we start first with existing curriculum in their environment. As I mentioned, there were communication skills as a core requirement that is not only part of the medical school curriculum, but also required by LCME and ACGME for the medical students and residencies in training. Developing curriculum, there could be a barrier to their development of additional curriculum or new curriculum, because there is the perception at present that communication skills are taught and that they should be sufficient for low health literacy. They don't send them out into the clinic thinking that they're sending them out with a deficit. At present, there's an assumption that this meets the need. Supporting here, though, is the health literacy data on patients-physician communication, and specifically in the outpatient setting. The references to the article, as well as a plethora of articles that I've looked at as part of my own project in curriculum and thesis development, support this second bullet. And then finally, looking at what it would take to implement the potential curriculum that this targeted needs assessment is trying to identify the gap or the need to create. The barriers are already the existing time and amount of information in the training program. You know, where are we going to fit more in when these folks are already stretched to their limits, so it seems. So there's going to be a barrier that needs to be approached with efficiencies and looking at what exists and seeing how it fits together and how we can build efficiently rather than just expand horizontally. And then there is a potential to linked learning, making sure that particularly in dealing with health literacy and patients confronted with lower levels of health literacy, that not only is the didactic training including that type of information, but it ties or links directly into clinical applications and feedback from those observing and supporting them in their rotations. In terms of supporting implementation of health literacy focused curriculum, the structure of the medical school coursework and the literature available on this topic both support to a great deal on the health literacy um, literature level, the ability to implement with a lot of data behind it, particularly for a group such as this, which is going to be research driven across the stakeholders and particularly the learners. And then the residency program, which in this case is community based, is the direct ability to apply and practice with real patients amidst the support and observation that will result in feedback as part of their training. So there's a direct application capability. And then finally, the resources. There is existing curriculum on communication skills. There's all of the literature that I've mentioned on the problem that we've identified, including some on the learners and their environment that we're trying to assess. And then there are curricula from similar programs across the U.S. that are implementing health literacy assessment tools and training to support their use in clinic. What are my unknowns? Okay, my unknowns are, what do the learners think? What are their attitudes about health literacy assessment? How do they feel about what they are receiving as part of their training? What is their knowledge level on the tools, skills, and the needs of their health literacy patients? Sorry, there's a typo. It should be patients, not patents. And what to do with those patients. And then behavior during rotations, which are their clinical application of their skills. How are they using the health literacy tools that are available to them, and how are they interacting with or communicating with patients that have lower health literacy challenges? This is where we need to obtain observation and input from the medical students and residents' use of health literacy resources. The environment, the content delivery of the communication, and the curriculum in this case is within the medical school training program but applied in the clinic. I need to know what that content is and exactly when it does fit into their curriculum, particularly if I'm comparing medical student versus residents in this particular targeted needs assessment. I need to know when in the training program are they getting this education, and where in the program are they expected to or giving real world practice on their skills to further develop what they've learned. So the article takes us to the pilot, which is a targeted needs assessment in the form of quantitative research with qualitative interpretation. The method here was the development of a knowledge, attitudes, and behavior survey, a questionnaire in essence, that is structured and designed to assess first the knowledge of how to identify low health literacy patients and use the health literacy tools when they communicate with those patients. So what do they know? What are their attitudes or perceptions of health literacy knowledge confidence? Are they confident? How do they feel about all of this in regards to the curriculum and training that they're receiving when they're put out to practice it and exhibit their knowledge? And then finally, what is their actual behavior? How are they behaving with these patients and using health literacy resources or communicating with patients? The pilot learners assessed, again, were the medical students and IM residents in Maryland and Pennsylvania training programs. And the environment are two community-based IM programs. So July 2012 through January 2013, they assessed this group through applying these surveys to get their feedback on what they know, what they feel, and how they're behaving relative to their training on working with low health literacy patients and resources. So finally, the results from this targeted needs assessment, they had 74 surveys returned from all of those that they sent out, and the full statistics on return rate by group can be found in the article which I posted. And looking at the three components of the survey, their attitudes, surprisingly 10% were confident in the level of health literacy knowledge, and 10% of them were confident in their low health literacy identification of patients and communication with those patients. This is different than what most of the literature would point to in terms of practicing physicians and in different studies, different learner groups, and different environments. Within this, only 1.4% were confident in appropriate health literacy resource identification, so knowing what to use when they're in that situation. When we looked at their behaviors, there was no statistically significant difference in the actual communication skills in clinic between the residents and medical students. There was also no statistically significant difference in their ability to identify appropriate resources with regard to training level, medical students or residents. And even though there were no differences in groups, again, we're talking overall that 10% fell into this confidence level. So 90% of this group were not confident in their level of knowledge and ability to identify and communicate. When we look at their actual knowledge, again, no statistically significant difference in actual measurable health literacy knowledge increase from their first year to third year in medical school. So they're not seeing a progression in knowledge through the medical school component of their training, and within the residents, they're not seeing a statistically significant difference or increasing amount of health literacy knowledge from internship to second year of residency. So what does all of this mean? Why do we care? In this context, our targeted learners, the medical students and residents in these Maryland and Pennsylvania programs, did provide the unknown information we needed to support the curriculum. This low percent of confidence reported in these groups, both medical students and residents, indicates they don't believe they have enough health literacy education during their training to feel confident in their clinical application of training and skills. They lack confidence in identifying low health literacy patients, identifying the resources to use, and understanding what communication skills are required to interact with low health literacy patients. In terms of the targeted needs assessment conclusion, coming back to the entire question of curriculum specific to the problem, the current curriculum or current curricula on health literacy is insufficient in these specific medical school and residency programs if we're turning out residents and medical students that are not confident in how they'll deliver care. The learning deficits range from identification of health literacy resources that is not progressing through their training programs, low health literacy patient identification, and the associated communication. So again, the communication skills component of their curriculum is not meeting this low health literacy patient need and providing them the confidence they need to implement what they know in the clinic. So the whole summation is that this targeted assessment does indicate a need. And the need is to develop curricula specifically focused on low health literacy individuals to integrate into the training for medical residents or medical students and medical residents in these programs. This would encompass identification of these patients. This would include the resources available to work with these patients, and beyond just patient communication skills, how specifically do they interact with low health literacy patients so that they can go into the clinic, and should this needs assessment or research pilot be conducted again, we would want to see that confidence level go up.